Hello, everyone, and welcome to our webinar, Obstetric Anesthesia and COVID-19 Challenges and Recommendations. I am truly humbled with the opportunity to moderate this webinar that the Saudi Anesthesia Society is holding in collaboration with the Saudi Society of Maternal and Fetal Medicine. Special thanks to my department for freeing me of clinical duties so I can actually be with you in this webinar. Obstetric scholars, institutions, and societies responded appropriately to the pandemic by publishing guidelines, pathways, and scientific papers on how to care for the obstetric patient with COVID-19. But most of that was before any of them actually cared for one of these cases. The preparation efforts worldwide were truly impressive, but we are holding this webinar to talk about the challenges we faced after all that preparation and what we learned from this experience. We will start off shortly with our carefully selected speakers, whom I will be very happy to introduce to you individually in queue. I received some questions on that question answer or Q&A box, and that's appropriate. This is where you should direct your questions instead of the chat box. Yes, there are CME hours for this, and there is a certificate with that. We will do our best to accommodate all questions in the last 15 minutes, but please feel free to type in your question in the Q&A box, and I will address every question, take note of that. Also, a link to this recorded webinar will be emailed to everyone who registered. For those of you who just joined us, welcome. Our first speaker today is a founding member of the Saudi Society of Maternal and Fetal Medicine. Dr. Yaser Faden is an obstetrician who specialized in maternal-fetal medicine, perinatal epidemiology, ultrasound, and medical education. He is an assistant professor and associate dean of postgraduate education at King Abdulaziz University, and chairman of Obstetrics and Gynecology department at King Abdulaziz Medical City in Jeddah. He will talk about the obstetrics and COVID-19. Dr. Faden, the mic is all yours. Thank you.
Thank you, Dr. Omar, for your great introduction. I'm just going to share the screen. Are you able to see the screen now?
Yes, we are.
All right, so first of all, I'd like to take this opportunity to thank Dr. Omar AlYamani and to thank the Saudi Anesthesia Society for inviting me to be with you this evening and share some knowledge with everybody here. It's a great honor and privilege to be presenting with the panelists we have tonight. And I'm sure we're going to be learning a lot of things related to pregnancy and COVID-19, whether it's obstetric-wise or anesthesia-wise. So my presentation is actually a story. So that's why I'm starting it with Once Upon a Time. And once upon a time, we had two very good friends. And these two friends were actually friends since childhoods. They went to elementary school together, middle school, high school. They graduated from high school and went on together to medical school. And from medical school, graduating from there, then they took two different paths. One decided to take on anesthesia and entered an anesthesia residency training program, while the other wanted to do obstetrics and gynecology. So we'll call the anesthesiologist Dr. A, and we'll call the obstetrician Dr. O. So Dr. A and Dr. O, they always met with each other, whether it's at work or outside of work, and they had lots of discussions on everything in life. But a great portion of their discussions were related to their specialties. One was an anesthesiologist, the other was an obstetrician. And sometimes, the discussions gets heated, especially when they were on call with each other. And things were not different at all with the COVID-19 pandemic. So Dr. A would usually discuss, universal screening and the importance of universal screening, during the COVID-19 pandemic, the importance of ensuring, that our healthcare workers are safe, whether the healthcare workers we're talking about were physicians, nurses, anesthesiologists, obstetricians, everybody. Dr. A would talk about, the proper use of PPEs, and also of having designated ORs for our pregnant ladies with COVID-19. While Dr. O, he would talk about, more selected screening instead of going for universal screening. He would, always tell his friend, Dr. A, that, whenever we're on call with each other and we call for a cesarean section stat, so please, you guys need to hurry because, it can have an impact on neonatal morbidity and or mortality. Maybe sometimes it's not enough, there's not enough time for regional anesthesia. And come on, about the OR. In LND, we have our OR room. So, consider that, please. So, they always had these heated discussions, and they agreed to sit down with each other and go over the evidence in order for them to be guided to the best practice when it comes to pregnancy and COVID-19 patients. So they came up with these topics: pregnancy and COVID-19. Let's review the literature, what we have so far, even though we know that it's limited. Let's review what's out there regarding testing protocols for women presenting in labor. Should we go for universal screening or we don't need to do universal screening? And then let's see what are some recommendations with regards to delivery for patients with COVID-19. So they went to the literature. They found that, with regards to transmission, pregnant women, they don't appear to be more likely to contract infection than other adult population. Pregnancy does alter the body's immune system, and therefore response to viral infections are different. And this can cause actually more severe symptoms in pregnant women, but they're still not more likely to be severely unwell compared to non-pregnant adults. With regards to vertical transmission, so according to the evidence that's out there, it seems to be possible. And this was considered based on 2 case reports showing that immunoglobulin M was found in neonatal serum. But a systematic review of 24 pregnant women, 8 studies, showed there was actually no evidence of the virus in the placenta, amniotic fluid, cord blood, or even breast milk samples. So a big question mark there. Is there vertical transmission or not? So what effect does COVID-19 have on pregnancy? So according to a systematic review by Zagam, published in April 2020, showed that most pregnant women with COVID-19 present with fever, 68% actually, followed by cough. Other symptoms includes shortness of breath, headaches, loss of taste or smell, anosmia, ageusia, and some of them are actually asymptomatic. They don't have any symptoms at all. Now this So Dr. A and Dr. O, when they were reviewing the literature, they came across this great study. Now, this was published in the British Medical Journal just 1 week ago, exactly 1 week ago, on the 1st of July, 2020. And why is this a very important paper? Because it's considered the largest prospective population-based cohort study to date, looking at this population, pregnant women admitted with confirmed COVID-19 and looking at their outcomes. So the data was from approximately just under 200 obstetric units in the United Kingdom, and the results are for 427 pregnant women who were admitted to the hospital with confirmed COVID-19 between the 1st of March and mid-April 2020. A lot of information can be extracted from this study. It's considered a United Kingdom Obstetrics Surveillance System interim report, so they're still collecting data. During this period, they found that the admission rate for those patients was approximately 5 pregnant patients with COVID-19 for every 1,000 pregnant women being admitted to these different obstetric units. 9% of those patients, of the 9% of the 427 required critical care, 4 women, so just under 1% received ECMO. 5 women from that population, from the 427, died, giving a COVID-19 associated maternal mortality rate of 5.6 per 100,000 maternities, and compare that to the 9.2 per 100,000 maternal mortality that was reported in the confidential inquiry into maternal deaths for the period of 2015 to 2017. In other words, it didn't show that there's increased maternal mortality due to COVID-19 and pregnancy. So also from this study, important study in the British Medical Journal, it showed that the most common symptoms that patients present with include fever, cough, and breathlessness. These were the most common, of course, and there are other symptoms. Now, it's important to know that we usually categorize patients with COVID-19 into mild, moderate, severe, and critical. Mild being those who are asymptomatic or having mild symptoms but have stable vital signs and they have no comorbidities, while those who are categorized as moderate have actually mild symptoms with stable vital signs, but they have comorbidities. Severe when there are abnormal symptoms or signs, and critical when there's shock or organ failure or patient requires mechanical ventilation or requiring ECMO. So what other results can we find from this study? As you can see here from this table, those who needed critical care, so 10% of the women needed critical care. About 1% needed ECMO, as we said. Regarding evidence of pneumonia on imaging was in a quarter of those women. So about 24% had evidence of pneumonia on imaging. Final outcome, again, fortunately, the majority did well and were discharged in a good condition, so more than 90%. Only 1% died, and at the time of the study, 6 were still in the hospital. So with regards to other pregnancy outcomes, most of the patients presented in the 3rd trimester or peripartum, so close to the time of delivery or for delivery or immediately after delivery. Another finding is regarding cesarean section. The cesarean section rate for these patients was high. About 60% ended up having a cesarean section. Regarding infant outcomes, so 25% of the newborns were admitted to the neonatal unit. 75% were preterm infants. Now, regarding positive testing of the neonates after delivery, so indicating possible vertical transmission. So there was 5% of those newborns who tested positive. Half of the 5%, so 2.5% actually tested positive within 12 hours of age. So again, increasing the possibility of vertical transmission of COVID-19 to the newborn. What else can we deduct from or summarize from the study? Most hospitalized were in the third trimester. We said the mean gestational age on admission was about 34 weeks. 42% didn't require iatrogenic births and were actually discharged while still pregnant. Of those who delivered, so as we said, about 60% had cesarean section. Half were due to maternal or fetal compromise. The remaining were for obstetric indications. Of those requiring cesarean section, 20% required general anesthesia. And I think this is a very important information for us. Why did they require general anesthesia? Either because they had severe COVID-19 symptoms or because there was an urgency to deliver them quickly. 10 patients needed respiratory support. As we said, 1% died. 70% of this population were overweight or obese. So now we're probably talking about possible risk factors. 40% were 35 years or older. 1/3 had pre-existing comorbidities. 12% had a preterm delivery due to respiratory compromise. Now let's discuss the testing protocols, which is, another hot topic discussed between amongst physicians, and especially amongst obstetric anesthesiologists and obstetricians. And when we talk about testing protocols, then we're really talking about universal screening. And what we mean by universal screening is testing all pregnant patients who present in labor for delivery. So Dr. A is really for universal screening. All patients have to be screened. It's logic. And Dr. O unfortunately says, well, Dr. A, it's really not practical. I mean, lots of patients come in active labor, a few hours, if not a couple of hours, and the baby's out. And we're not going to get the results before that. So again, a hot topic. We need to keep in mind that COVID-19 came and had a significant economic burden on countries because of the lockdowns all around the world, and also had an economic impact on hospitals and hospital systems due to the massive screening of patients, due to the consumption of PPE, due to increased ICU admissions, and not just ICU admissions, just regular admissions to the hospitals in different wards. Now, when we're talking about universal screening, what made us, what triggered all this discussion? It was triggered by a few studies that were published, and this is one of them. So this study by Breslin and her colleagues, that was conducted, the testing occurred between March 13 to March 27, so over 2 weeks. And according to this study, they found that the prevalence of COVID positive in asymptomatic patients was about 33%. So that means that, patients who present and they are asymptomatic, 33%, a third of them are actually COVID positive, of asymptomatic patients. And that's a significant number. Another study here by London and colleagues, again from a New York hospital, and testing period March 15 to April 10, the prevalence again was close to 33%, were the prevalence of asymptomatic patients who were COVID positive. Another paper in the New England Journal of Medicine, March 22 to April 4, 13%. Here in Mount Sinai Health System, also in New York, April 4 to 15, the prevalence was 16.3%, so less than the previous studies, but still probably a significant number. But this paper here, showed low prevalence amongst, pregnant patients and postpartum patients that had universal screening in Seattle. So this was, other side of the United States. And in this study here, the prevalence was low, so 2.7%. Another study published in JAMA in Connecticut. So in Connecticut, the prevalence again was low, 2.9% to just under 3%. And that led to articles coming out and questioning, do we really need to test laboring women? Or should we just go according to regional prevalence? So for example, in Los Angeles, the researchers there, they stopped universal screening when they noticed that none of the first 80 patients, 80 asymptomatic women, had positive results. Researchers in Chicago, even though their prevalence was also low, 1.6%, but they decided to continue to test all patients and go for universal screening. So at the end, there's probably no one-size-fits-all solution to this regarding universal screening or being selective. It all depends on the prevalence, the regional prevalence of COVID-19 infection. So we need to determine the prevalence of COVID-19 infection in our area and possibly in our hospital, because we know that hospitals can also differ in their prevalence. But we can probably recommend that in the setting of a low population prevalence of COVID-19 or in locations where there's limited testing availability, we can defer universal testing. And that might be a better choice, weighing risks, benefits, economic burden, and also unintended consequences. While in high prevalence regions, then universal testing may be a valuable addition to obstetric care and can prevent infections of healthcare workers and also neonates. So universal screening has its advantages that we all know of, but there are also unintended consequences, delay in care, due to healthcare providers spending more time donning, PPEs, probably stigmatization of patients and separation from the newborn, cost effectiveness, and other points to consider regarding, that probably each healthcare facility, they need to study their own abilities to implement universal screening. And it's going to be each facility or each center's decision at the end. They need to take into consideration how quick the results are going to come back in order for them to manage laboring women in ICU isolation beds. We need to consider the rate of disease transmission. We know that it's low with asymptomatic infection compared to symptomatic infection. And as we mentioned, the rate of vertical transmission is fortunately also low. So recommendations regarding screening, WHO guidelines, they recommend lab testing for all suspected cases, so symptomatic patients. ACOG and the Royal College, CDC, they recommend testing at the provider's discretion. So therefore, testing criteria are going to vary by institution. We consider testing for patients being admitted to labor and delivery or those who have a planned admission when we schedule them for induction of labor or cesarean delivery within the next 48 hours. Those would be a good population to consider for testing, very important to test them. Support persons, if we allow support persons to be with our laboring women, then we need to consider testing them also. Experience from our hospital, from King Abdulaziz Medical City in Jeddah, in order for us to decide, do we really need to go for universal testing or not? We also analyzed and we found that from April to June 25, so almost 3 months, we had 347 deliveries, 201 was screened. So that's a 58% screen population. But actually, if we look just at the month of June, 83% of our patients were screened. So that's close to universal. We found that there were 4 who tested positive and they were asymptomatic. So our prevalence of asymptomatic carriers was only 2%. So that's low prevalence. Now, the last part is delivery considerations. So delivery considerations regarding mode of delivery, we always prefer vaginal delivery. Cesarean birth was for the usual obstetric indications. Intrapartum, these patients need to be delivered in negative pressure isolation rooms. If we don't have negative pressure rooms, consider delivering them in a room, but bring a HEPA filter. These patients, we need to assess the severity and categorize them. As we mentioned earlier, always, management should be in a multidisciplinary approach. Full PPE is recommended in patients who are COVID confirmed or suspected. We need to minimize personnel in the labor room as much as possible. All patients and providers are recommended to wear surgical masks with each encounter. Full droplet precautions for patients with respiratory symptoms, but those who have suspected or confirmed COVID-19, then full PPE with N95 masks, gloves, gowns, surgical masks with face shields. And for any patient also, regardless of the respiratory symptoms, during an aerosolizing procedure and also during the second stage of labor, full PPE is recommended. For a cesarean section, surgical team to apply full PPE donning. They need to wear the N95 respirators for cesarean, even if it's going to be a spinal or epidural anesthesia, because we know that there is, the spinal epidural anesthesia can be converted anytime to GA. So that's why the full PPE is recommended. Good practice points: postponing the elective cesarean section until the patient is cleared. Scheduling patients at the end of the OR list, taking the appropriate precautions during transfer, patient transfer, especially when we're transferring them from the delivery room to the designated OR room for these patients. It's considered good practice to have obstetric drills and simulations. We had an obstetric drill in our hospital that was initiated by our colleagues in anesthesia, and it was very, very helpful for both departments. Now, with regards to unscreened patients, and I'm finishing my last couple of slides. So with regards to unscreened patients, so patients who present, they weren't screened, and they have to undergo emergency surgery. So I'm just showing you an example of a great collaboration that we had between our department and the Department of Anesthesia with, as you can see here, it was signed by the chairman of anesthesia and also by the director of the OR, who is also an anesthesiologist, great friends, great colleagues. And also we included our associate executive director of infection control, and we agreed on a few points with regards to patients who present for an emergency, needing an emergency surgery, but they were unscreened. So again, this is very important that we sit down with our colleagues and come up with resolutions. And this is what actually Dr. A and Dr. O did. So they decided, after reviewing the evidence, they sat down together, multidisciplinary team meeting, but not, that COVID-19, they can't sit down like this, right? So that's a no-no. So they had a virtual meeting, and after the virtual meeting, they came up with a resolution. They came up with a policy and procedure with regards to different aspects of caring for COVID-19 pregnant women and things related to anesthesia, and they lived happily ever after afterwards. Thank you very much.
Thank you very much, Dr. Yaser, for this very informative presentation. I need to share my screen here. Okay. Perfect. So for everyone else who just joined us, this is the OB Anesthesia and COVID-19 Challenges and Recommendation webinar arranged by the Saudi Anesthesia Society in collaboration with the Saudi Society of Maternal-Fetal Medicine. Dr. Yaser Faden, who just finished his wonderful talk, is a founding member of the Saudi Society for Maternal and Fetal Medicine. Thank you very much, Dr. Yaser Faden. I am your moderator for this webinar. My name is Omar AlYamani, and I am an assistant professor of anesthesiology, obstetric anesthesiology, and pain management at King Abdulaziz University. And again, for those of you who just joined us, your cameras and microphones have been disabled. You can submit your questions to the Q&A box. If you have any technical issues, please close your browser and restart the webinar. I've been getting many questions about certificates and names. These things are automated, and your certificates will look like the name you entered when you registered for the webinar. The Saudi Anesthesia Society will release a statement following this webinar, and this whole webinar is being recorded. It will be a link for that recording will be emailed to you with the certificate. And an overview of our program, Dr. Yaser Faden just spoke to us about the obstetric view of COVID-19 pandemic. Our next speaker will be Professor Bhavani Kodali, Professor of Obstetric Anesthesiology. And then finally, there will be short case presentations before answering the questions I'm collecting at this moment. These short cases will be presented by Dr. Adil Al-Qarni, Dr. Muhammad Al-Jahdari, and Dr. Atimad Bantan. Quickly, before we move on to our next speaker, I just wanted to share with you this yet to be published statement from the Saudi Anesthesia Society that was approved by the Saudi Society of Maternal-Fetal Medicine on the use of meperidine. And I honestly thought that it would be helpful to put this statement and to alert you about this statement, since I have the attention of most obstetric anesthesiologists and obstetric anesthesia providers in the country, probably in neighboring countries too, to just point your attention to what the Saudi Anesthesia Society thinks about meperidine for labor and delivery. This statement will be published soon. And now moving on to our next speaker. Our next speaker is actually my teacher and my role model as well. I had the humbling experience of working with him at University of Maryland, where he chairs the Division of Obstetric Anesthesiology. Dr. Bhavani Kodali is a professor of obstetric anesthesiology who worked for 20 years at Harvard Medical School and Brigham and Women's Hospital from 1998 to 2018. He's a well-known scholar with 2 pages full of honors and awards, developed many clinical programs around the world, worked in 5 continents, and was the first scholar to publish a paper on how end-tidal CO2 reflects arterial carbon dioxide in 1986. That very article was the first to eventually lead to our current practice in anesthesia, and was the first to describe cause, and Dr. Kodali was the first to describe the cause of decreased arterial end-tidal CO2 difference in pregnant women. He was also the first to describe the concept of dual capnography in 2-lung ventilation, and a key member of the committee that developed the standard nomenclature for the components of capnogram. He created the wonderful websites, capnography.com. I advise you to check that out, and painfreebirthing.com. He proved that amniotic fluid is a procoagulant among nearly 150 other peer-reviewed published articles. He currently has 3 active research grants and have completed 30 others of grants. He wrote 5 books and 19 chapters in other books. Ladies and gentlemen, if you think this was a long introduction, please note that Dr. Kodali's CV is a staggering 76-page long CV. I haven't come close to mentioning even 5% of his wonderful contribution to the field of anesthesiology. You kind of have to wonder, where does he get the time? I hope he answers this question during his presentation. I will leave the mic now to the godfather of capnography, Dr. Kodali. The mic is yours. Thank you. And please.
Thank you. Thank you, Dr. AlYamani, for that kind introduction. Now, Dr. Yaser Faden has actually given a very good overview of COVID-19 in pregnancy. He has almost covered everything. But here, what I'm going to do, in fact, he made my job a little easier. But what I'm going to do here is, I'm going to talk about challenges and recommendations and what is a practical approach to an unforeseen complex problem. We were all taken by surprise, as you all know. And of course, I have no financial disclosures except that I do maintain the 2 websites, which is the capnography.com and the painfreebirthing.com, which Dr. AlYamani has alluded to. Now, I would like to make 3 comments. The approach to manage COVID-19 differs, may differ based on the, based on each area, as Dr. Yaser Faden has mentioned. What is possible in some institutions may not be possible in other institutions. That is another thing. But however, the basic principles apply to all. Now, what is available in plenty, to all of us is clinicians and healthcare providers with great skills and knowledge all over the world. Creativity and ingenuity of the team is one of the key factors that dictate how you manage a crisis like this. And thirdly is quick adaptability to a new system. And everyone has to adapt to a new system in order to succeed. There are certain few factors, at least 3 factors that are relevant to COVID-19 in obstetrics. There are no electives to cancel. We have to keep going because, labor occurs all the time. We have to protect other patients from known or unknown pregnant patients. And this is one of the key factors which we have to remember. And the third thing is we have to protect healthcare personnel who are taking care of the pregnant patients, because stat interventions like Dr. Faden has mentioned are a part of our practice in obstetric anesthesia. And we know that some of the healthcare providers were infected with COVID and they lost their lives. So it becomes an onus on us to prevent, to take care of our personnel, all persons working in the COVID-19 area. Everyone is vexed with this picture, but however, we need to understand how coronavirus behaves in pregnant patients in order to get some insight into how this manifests in pregnancy. Now, as you know, that the coronavirus binds to the ACE2 receptors, which is angiotensin converting enzyme 2 receptors, and they make way into the cells, and there is a viral replication, and the viral RNA helps to mature and produce more viruses, which are released into the airway and becomes a source of infection to the others. At the same time, it produces pyroptosis. Pyroptosis means there is a programmed cell destruction, and therefore there is the destruction of the epithelial cells. Now, these factors that are released, which is ATP and the nucleic acid and ASC oligomers, they actually invade the endothelial cells, the epithelial cells, and the alveolar macrophages, thereby producing the destruction. At the same time, it also triggers a massive cytokine release, or the chemokines, which includes the IL-6 or IP-10, and they produce the systemic effects of COVID-19. Now, as pointed out earlier, that majority of the patients are asymptomatic. 85% of the patients are asymptomatic, but about 15% of the patients may exhibit severe disease, and this number can vary from region to region. And when in the 85% of the patients, there is a healthy immune response which is mediated by T lymphocytes, T cells, and also neutralizing antibodies, and that destroy the virus as well as the cells affected by the virus. However, in the 15% of the patients, the cytokines which I alluded to are released into the systemic circulation, thereby producing the full-blown COVID-19. How does pregnancy respond in such a situation? We know that pregnancy is an immunological indolence. That means the immunological system in pregnancy is actually lazy. That means it is slow in response. This is because of changes in the cell-mediated immunity and also in the lymphocytes, in their response, and also the decrease in the T helper cells, and also there's upregulation of the humoral response. So because of that, there is an immunological indolence in the pregnancy. Now, how do these viruses, or how do the pregnant women respond to these viruses? we can take some history here. When there were H1N1 or H2N2, when we had all these pandemics, the pregnant patients actually did not do that well, as you can see. In 1918, 25 to 50% of the pregnant women had a higher case fatality ratio compared to the non-pregnant. And there were 20% of deaths in H2N2 in 1957. And in 2009, there were 4 times the hospitalization and 5 times the mortality in H1N1 as compared to the non-pregnant population, as highlighted here. Now, when you compare to SARS and MERS, probably the COVID-19 pretty much behaves in similar fashion. But the mortality when these papers were published, it was 0. But as Dr. Faden has alluded to, pregnant patients do die of COVID-19. Now, when COVID-19 landed in United States and became prevalent in this country, a multidisciplinary team followed, and we actually made some adaptive changes in our labor and delivery. And this is just going to be published in the Journal of Disaster Medicine. And I will highlight few points. We had about 31 pregnant patients that went through our system because ours is only a referral center. Now, our L&D is about 12 rooms. And as you can see, a barrier was constructed to isolate 2 of the negative pressure rooms, like room 8 and room 9. And this barrier was constructed in a matter of 4 hours by the engineering department. When you look through the glass of the barrier, you can see the two labor rooms, 8 and 9, with a doffing and donning area suitable to put on our PPE and enter the rooms. This is just a long shot of the view from the other side of the labor and delivery area. Now, the adjacent room, we actually have kept a ventilator ready, an ICU ventilator ready, and also a laryngoscope and an operating room table for emergency section and all the airway equipment. And we also had this protective equipment, the personal protective equipment ready at the entrances so that when there is a stat section, we have everything on hand to provide immediate care to the patient. This is inside the labor and delivery room, which is, as you can see, it is all ready to go. Even a cesarean section can be performed here. And as Dr. AlYamani alluded to, we also had the end-tidal CO2 hooked up to the monitor to confirm the endotracheal tube placement right away. And of course, the ICU ventilator ready to go. Now, we also had one operating room, which is negative pressure, 1 floor above for cesarean sections for COVID-19 patients. And the main operating suite had about 3 more negative pressure rooms available to us if there is more rooms needed in addition to the one closer to us. In addition to all the operating room and L&D facility preparations, we also, of course, every hospital had what is called as the biocontainment ICUs earmarked for the COVID-19 patients. Now, these intensive care units, there must be a provision for stat cesarean delivery because we don't know when a pregnant patient is being ventilated, when a cesarean section need arises. And there has to be a neonatal resuscitation bay adjacent to these rooms. And cesarean delivery equipment should be at hand every time. And a group communication system to summon the team for a stat delivery because the patients are managed with the ICU team, but the cesarean section is done by the obstetricians. And of course, we take care as anesthesiologists too. And each case is followed by a debriefing to improve the system because these are the ongoing systems and that needs to be debriefed and improved upon. The pharmacy was very good and kind enough to prepare special COVID boxes so that we can use the drugs, clean up the boxes, which are unused vials, and then they can restock it. So they contain all the drugs that are necessary for an emergency cesarean section. As you can see, this is an airway equipment which has been ready to go. Now, let us look at the flow of the patients. Now, the patients arrive into a triage area, and the nurse with the PPE equipment does the COVID-19 test. Initially, our tests came very, very quickly. They used to come in 1 or 2 hours. But now, of course, nowadays, because of the increasing number, it is taking a little longer. If an intervention is required before the results, which happens in the obstetrics because of emergency nature of the delivery, a labor epidural is placed in the L&D room, and anesthesia, suppose if a cesarean section is required, anesthesia is provided with PPE equipment in place by the anesthesiologist, particularly an N95 mask on top, and then there is another mask on top of it and a face shield if there is no time to wear a PAPR. If the COVID-19 test came positive and the patient is stable, the patient goes to the negative pressure room, which is a labor and delivery negative pressure room, and the nurses and the anesthesiologists or everyone who provides care wear the personal protective equipment. If the COVID-19 test came negative, then the patient goes to a regular room. But however, we still place the epidurals and also during the delivery with N95 mask and a shield because of the asymptomatic carrier that could be, as this patient could be an asymptomatic carrier. Or because sometimes the test may come as a negative, but as you know that there are false positive and false negative, and that is why they could be an asymptomatic carrier. If the COVID-19 test is positive and the patient is unstable, then they go to the designated ICU, and the ICU ventilator uses the HEPA filter on the expiratory limb. Just remember that originally the ICUs didn't have the HEPA filter. So in the expiratory limb, and a HEPA filter must be placed in the intensive care unit if being used for COVID-19 patients. Now, if the cesarean delivery is indicated for the case, then a designated OR can be assigned and the patient can be transported. However, if a stat cesarean delivery is required in the ICU, then we should be able to perform the cesarean section in the ICU itself. As pointed out by the obstetrician just previously, that the testing rate can vary. Initially, the testing rate was 4% for us, but now it is roughly 2%. This is a positive test upon testing a lot of patients who come here. We had about 31 patients, but the 2 patients were actually once upon a time positive, but they were negative and they had a normal vaginal delivery and left. But these 29 patients I will highlight to tell you how these patients can take or behave during COVID-19 infection. One patient had a vaginal delivery without epidural, one had vaginal delivery with epidural, and one was a vaginal delivery with a combined spinal epidural, and one a cesarean delivery with combined spinal epidural. Uneventful, no issues at all. This is a little bit a figure which is slightly higher than reported in the literature. 31% of the patients that were admitted to our hospital with COVID-19 required ventilation, and 1 patient went on to ECMO. Probably this is a skewed up figure because of the nature of our center being a high referral center. So in the ICU, what happened? 3 patients required cesarean delivery. 1 was an urgent cesarean section. Therefore, there was time enough to move to a negative pressure room, and the cesarean was done on the ICU ventilator itself, very uneventful. There were 2 patients who required stat cesarean section in the ICU, and they were moved to the OR after the cesarean section for abdominal closure because this patient had a massive diarrhea. You know that some of the COVID-19 patients can present with massive diarrhea, and there was so much of contamination on the bed that the patient was moved to a negative pressure OR, and then they did a lot of cleaning of the abdomen, irrigation, and then closed the abdomen in the OR and brought back to the ICU. And why the stats section occurred, one was an intubation desaturation. The patient was intubated because she was desaturating, but the desaturation continued and there was a fetal bradycardia. The second one was a self-extubation, and therefore the patient had to be re-intubated, and then the patient had desaturation that led to fetal bradycardia. One patient actually delivered vaginally in ICU on ventilator itself. So 26 patients went home, one readmitted to another hospital because she had pneumonia, but not on a ventilator. And one is still in-house who was extubated and required a little bit of oxygen even now in the labor and delivery room. There was one patient who went on an ECMO and she died. This patient had preeclampsia and HELP. So if a patient has got more comorbidities or complications of pregnancies such as a HELP or a preeclampsia, one has to be extremely careful in the management of those patients. But in general, whoever came to our hospital did fairly well. So what are the key observations? First observation is ICU stat cesarean sections. And this is something which I want to focus as an anesthesiologist and particularly as an obstetric anesthesiologist. So this is the uteroplacental unit with a placental buffer between the mother's blood and the baby's blood. Normally, we need about 25 ml per minute of oxygen for the uteroplacental unit. However, in a normal pregnant patient, approximately 150 ml per minute of oxygen is available at every time, but the unit requires only 25. What it means is there is a lot of buffer in a healthy pregnant patient for oxygen. However, when the lungs are deranged, like in COVID-19, the oxygen flux buffer can be decreased and the patients could be at the lower margin of the buffering threshold. So that means it is precariously balanced in those patients. That means the baby is still fine, but it is precariously balanced because the buffering capacity is low. Now, when there is a variation in oxygenation or cardiac output, when such as an intubation or a re-intubation in a pregnant patient, then the fetal oxygenation can decrease and lead to fetal bradycardia and can lead to stat cesarean section. So therefore, some precautions have to be taken in the ICU, particularly when these patients are being intubated, and they need extraordinary amount of pre-oxygenation before actually embarking on putting the tube if time permits. You pre-oxygenate them as much as possible. This is a circuit like a Mapleson C circuit with a HEPA filter, and the patient can be pre-oxygenated with such a circuit with 100% oxygen. Then, as soon as the patient is intubated, some precautionary measures have to be taken. Hyperventilation should be avoided because it decreases cardiac output. Low tidal ventilation may not acquire alveolar recruitment. So therefore, you may have to use a little bit of a high tidal volume initially, and the respiratory rate should not be that high because you don't want to impede the cardiac output. And excessive PEEP should not be used initially again. And the reason for that is it can increase the mean intrathoracic pressure and also decrease the cardiac output. A decreased cardiac output decreases the uterine blood flow and therefore can produce fetal hypoxia and bradycardia. Therefore, we have changed our philosophy that initially, as soon as we intubate these patients, we go a little slow with a high tidal volume ventilation and then change over to the ICU settings once everything is stable. The normal medications that were used were ethomidate, succinylcholine, rocuronium for long-time ventilation, and also propofol and fentanyl infusions. The ICU parameters were respiratory rate was generally between 16 and 26 per minute. Tidal volumes were 350 to 400 in the ICU stay, and the PEEP that was used were 10 to 16 centimeters, and patients were changed to supine to semi-prone as permissible by the abdomen in order to maintain the oxygenation in these patients. So many patients were prone many times during their stay. Normally, the PaCO2 needs to be maintained around 34 to 38, and end-tidal seems to be a reasonable guide, even though the lungs are deranged here. As you can see, the end-tidals were 32 to 38, and the PaCO2 was 34 to 38. So it is reasonably closer as a guide to the end-tidal as a guide to the arterial CO2. The pH is, should be maintained around 7.4. HEPA filter on the expert report is a must for all ventilations. The other key observations are overall the pregnant patients did well, as I pointed out. Pregnancy itself is a physiologically adaptable to stress. So because of that, probably they are doing well despite the immunological indolescence, which I did explain in the beginning. The patients we observed that had a higher fibrinogen, as you can see, the mean was 668 and up to the higher level of 994. And the normal fibrinogen in our population was about 268 to 620 as a range. The D dimers were elevated in these patients with COVID-19, and the platelets were also elevated, as you can see, up to 640,000 in some patients. And 5 of ventilation patients, that means 5 out of 9 had D dimer products greater than 2000. So probably the fibrinolysis does occur in these patients, as shown here. Now, although we did not observe thrombocytopenia, there is a meta-analysis that thrombocytopenia can occur in these patients, and if this occurs in COVID-19 patients, it does indicate a very severe and worsening illness. So this has to be kept in mind. If our patients with COVID-19 where there is the thrombocytopenia, particularly in pregnancy, that means we are probably heading in the wrong direction in this patient. What were the medications that were used? No treatment in asymptomatic patients, and a combination of antibiotics like ceftriaxone and zithromycin. Hydrochloroquine was used once, but now it is gone, as you know, and remdesivir is currently being used, and dexamethasone is also being used currently. Regional anesthesia is the way to go in COVID-19 parturients. We can wear PPE while doing these procedures, and at least an N95 mask with a face shield. And face mask can be put on the patients also, and non-rebreathing oxygen masks can be used in pregnant patients without fear of aerosolization. And once our epidural is in place, we don't normally enter the room too often, but use the remote iPads as shown in this picture to monitor the patient. Now, if general anesthesia is required, in the ICU, we are using full gear like PAPRs for intubation for stat sections. But in the general anesthesia in the OR, we either use the PAPR or the N95 regular mask on top of it and a shield. If the patient is in the ICU ventilator and needs to be transported to the OR, we can use the same ventilator with HEPA filter from the operating room, to the operating room and back to the room, so that we avoid any disconnection between the endotracheal tube and the ventilator. This is one of the important observations we made, that there were no issues with hemodynamic stability. You can recall a patient from China, a paper from China that said that when they were using neuroaxial, there were a little bit of a exaggerated hypotension, but somehow we did not observe this finding here, even during general anesthesia or as well as regional anesthesia. This is just to show that you have a lot of options depending upon the availability, and N95 with mask and the shield seems to be a reasonable option. Now, they're all reusable, as you know that, of course. Now, one thing which you all have found out probably by now, when we wear all this equipment, it is very, very difficult to communicate. You have to really make an eye contact with the person to understand what that person is telling because of the background noise. So our outcomes have been all our admissions went home, which is good. Some delivered, with or without regional, and regional were uneventful. 2 stat sections and 1 urgent cesarean section, they all did fine. Now, this was one of the findings. We had 3 fetal deaths in 31 pregnant women who came here. This could be, although Dr. Faden has just said that there is a little bit of vertical transmission, or it is a coincidental death in these patients, only time can answer. Maybe more patients, more data will tell us is the fetus and the babies are affected by COVID-19. 1 patient who went on ECMO and died, as I alluded to. As pointed out before, the practice is evolving. We have to be very practical in our approach because this COVID-19 is not going to go away that easily, at least in some countries and particularly ours. So as you can see, we have 3 operating rooms, but they are all positive pressure. There's no negative pressure here. So what we have done is we have just put, there is a HEPA filter for the operating room. So there is a HEPA filter in the ventilation system, and the ventilation system clears the air at 32 times per hour. In addition to that, we have added a portable HEPA unit here, as you can see in this picture. In addition, in the corridor, we thought of putting another HEPA filter here in the corridor too, but our engineering guys said that it is not necessary. If you have the HEPA filter in the operating room, that is good enough. And we have also decided that most for any patient, whether COVID positive or negative, it is better to use at least an N95 mask with a face mask and a shield all the times so that we are all protected all the time. More evolving strategies. All patients are tested in the clinic or on admission. So that is something that is being done. But the patients can refuse in the state of Maryland. And therefore, if they refuse, they are treated as if they are COVID positive with all precautions. Nowadays, the testing is taking a little longer now because of too many tests. It takes sometimes 4 to 5 days or even 7 days at some places. And if they refuse, as I said, treated as COVID-19, and guidelines keep changing. This is something, as I always say, the guidelines keep changing, and therefore we have to be adaptable to this system. These are the something guidelines which I can send if someone is interested, but this is nothing new. This is actually based on the CDC, particularly as you can see, if someone has got less than 10 days and first positive COVID RNA, they are COVID confirmed. Inpatient greater than 10 days and less than 42 days. If testing does not revert to negative, they are again COVID confirmed. And if they're greater than 10 days outpatients, but less than 42 and no symptoms for more than 72 hours, it is COVID recovered. And greater than 6 weeks after the first positive test, then they are fine as a normal patient. So what is the final analysis? No single strategy of anesthesia is the final approach. All depends upon how the parturian presents, what is the nature of urgency. Regional is the way to go where feasible. Caution in parturients with respiratory distress, because once you give regional and the patients have got a compromised respiratory distress, then you may have to emergently intubate them. So therefore, it is a judgment call where you have to give general anesthesia versus regional. Patients on ventilator will have IPPV continued, and general anesthesia where fetal indication of urgency, is, if there's a fetal indication of urgency, general anesthesia is the way to go. General precautions of COVID-19 must be enforced and be safe and protect others. And as I always say, common sense should prevail when we make our decision and an approach to these patients. Thank you and shukran, and take care and also protect others. Thank you so much, Dr. AlYamani.
Thank you very much, Dr. Kodali. If you can unshare your screen.
Sure.
At this point, that was a great and, as usual, wonderful presentation by Professor Bhavani Kodali, Chair of the Division of Obstetric Anesthesiology at University of Maryland. Thank you very much. Of course, we have a lot of questions that we're going to delay until the end of this presentation, of this webinar. I'm sorry. And this concludes our main presentations of the webinar, but we now have the short case presentations, starting with Dr. Adil Al-Qarni. He is an assistant professor of anesthesia and a consultant at King Saud University, and he is the head of the unit of obstetric anesthesia. Dr. Adil, the mic and the share screen are yours.
Okay. Good evening. Thank you for invitation. I would like to share with you our case of COVID-19 who had an urgent cesarean. So during my duty, we were called by obstetric on-call team for an urgent cesarean for a patient for a positive COVID-19 patient. The reason for cesarean because the patient was on active labor while she had a history of previous to cesarean. So this is a case of 42 years old lady, gravida 5 para 4 plus 0 at 36 plus 5 weeks of gestation. She is known case of gestational diabetes, well control on diet. She had a positive COVID-19 test, which was done 13 days ago. The reason for the COVID-19 test, because the patient had a low-grade fever and fatigue, which lasted for a few days. Upon her admission to our hospital, she was completely asymptomatic. An eventful pregnancy, an unremarkable surgical history except for the previous 2 cesarean. Unremarkable obstetric history. So in conclusion, this is an urgent cesarean delivery in a multiparous woman who was in active labor while she had a scarred uterus from the previous 2 cesarean. She had a positive COVID-19 test 13 days ago. She was symptomatic for 3 to 5 days post-test. She was swabbed in our hospital, but usually it takes 8 hours to get the result. So as long as it has been less than 13 days since the onset of the symptoms, we decided to deal with this patient as a COVID-19 case. Preoperative lab results were acceptable. Our plan of spinal anesthesia was discussed with the obstetrician and then accepted by the patient. We decided to do the procedure in a negative pressure room. Intra-op standard monitor, then the patient was positioned in a sitting position. Neuroaxial ultrasound was done merely to determine the midline and to locate the L4, L5 level. Then the spinal anesthesia was done by using 27 gauge needle, 11 milligram of bupivacaine plus 20 intrathecally. Phenylephrine infusion was started to prevent postspinal hypotension, and we had adequate sensory level. During cesarean, no breakthrough pain, and the hemodynamic was maintained with phenylephrine infusion. The patient had 1 episode of hypotension with low heart rate, which was treated with 5 milligram of ephedrine. The newborn was doing well with Apgar of 8 and 9. Postoperatively, the patient was shifted to isolated recovery room in a stable condition with SpO2 of 99 on room air. The COVID-19 test, which has been done in our hospital, came back positive, and then the patient discharged home at day 3 post-op. In this slide, I would like to share with you the measures which have been done to minimize the risk of transmission of infection. So the procedure was done in a negative pressure room. We tried to minimize the number of healthcare workers inside the OR. All the healthcare workers involved in the procedure were PPE, and we asked the patient to wear surgical mask throughout the procedure. Spinal rather than GA was done, and the IV stand with injecting port and infusion pump kept a little bit away from the head of patient. Doing spinal is not the end of story. You might need to convert to GA at any time. So to decrease the risk of failed neuroaxial, the spinal was done by the most experienced anesthesiologist who was available at that night, while the cesarean was done by a senior obstetrician to minimize the operative time and to decrease the risk of complications. Neuroaxial ultrasound was done to facilitate the procedure, and a combination of adequate dose of local anesthetic plus lipophilic opioid was given intrathecally to get a good quality of block. The last 2 points, we didn't do it, but retrospectively, I think it would be better to go or to perform combined spinal epidural to cover any unexpected extended surgical time. And in a case of doing spinal anesthesia, especially in obese patient, going for a little bit bigger non-cutting needle will make the procedure easier without increasing the risk of post-dural puncture headache. Thank you.
Thank you very much, Dr. Adil. And our next case presentation will be by Dr. Mohammed Al-Jahdari. Dr. Mohammed Al-Jahdari is an associate consultant at the anesthesia department at King Abdulaziz Medical City. Dr. Mohammed, the mic is yours. And please share your screen.
Assalamu alaikum. Good evening, everyone. First, I would like to thank Saudi Anesthesia Society for organizing this event. It is indeed a good opportunity, a good platform to exchange knowledge and experience during these difficult, extraordinary times. I would also like to thank my colleagues for their contributions and everyone for attending the event. In the next 5 minutes or so, I will present to you a short case on actual anesthetic management of COVID patients. Okay. Our case done on 17th of April 2020. And at that time, I believe the early stage of the pandemic in Saudi Arabia, maybe the dealing with COVID patients is more challenging, more difficult than these days. Our patient is a 37-year-old lady, medically free, gravida 4, bara 3, 39-week of gestation, presented to emergency department in active labor. The thing is, her acute respiratory illness score, ARI score, was 7 due to direct contact with another positive COVID patients, her sister actually. The ARI, just a brief about the ARI. ARI is developed by Ministry of Health. It is a visual triad checklist score that include both history of exposure and history of travel and any clinical sign or symptoms. If that score is more than 6, isolation should be considered and the COVID-19 test should be done. So as I mentioned, our patient was having a ARI score of 6. So the ID team informed, infectious disease team informed, and the patient admitted to an isolation room, and the nasopharyngeal swab for COVID PCR has been taken. At this stage, anesthesia team informed. And actually at that time, as I mentioned, it was in the beginning of the pandemic, so we had the conflict. On one hand, why should we expose our healthcare worker to a COVID risk by doing epidural for a multigravida who is already 7 centimeter dilated cervical and might deliver at any time. On the other hand, without this epidural, if we didn't insert epidural, this patient might push for an emergency C-section, and we will have no options other than GA and intubation, which carry more risk for virus transmission to healthcare workers. Thanks God, at that time, the recommendation from Saudi Anesthesia Society was already released, and they recommend to do epidural as early as possible to avoid airway manipulation, as we mentioned. And we did that. We did so. So we did the epidural anesthesia inside the isolation room, full PPE, gown, shoes cover, goggles for the eyes, and N95 and gloves, and head cover also, as I mentioned. So we did the epidural. Later on, it was decided to take the patients for emergency C-section. So thanks God again, we have a designated operating room at that time with HIPAA filter, with trained people. So we pushed the patient to that designated room, a limited number of OR personnel. For example, in our department anesthesia at that time, we designated one anesthesiologist inside and one anesthesiologist also with full PPE waiting outside the room in case of emergency. Anesthesia technician also, we have 2 persons, one inside full PPE and one outside also full PPE for emergencies. Once the patient is in, standard monitor applied and epidural top-up given. We gave 15 ml lidocaine 2% plus 100 microfentanyl, so total 17 ml volume given to that patient. And cesarean section started and patient and baby delivered successfully. Patient recovered in the same room inside the operating room, and then from the operating room directly, not to Baku, Baku was inside the operating room, so directly to the isolation room. Next day, swab result that we took yesterday became positive, and second swab then also in the day 5, and it was also positive. We meet the patients, anesthesia department and the infectious disease team and the obstetrician through a video call. Patient remained asymptomatic and on the day 5 transferred to a quarantine under the umbrella of Ministry of Health. Anesthesia team was advised by the ID team to go for testing, anesthesia team that involved in this case, to do COVID swab testing and to start home isolation. The swab testing we did showed later to be negative, and again advised by the infectious disease team to stop home isolation and to resume work. So this is our case, just to highlight the points that I think we did well because of. Number one, they were early detection by using ARI score and confirmation by PCR testing. There were excellent communications between multidisciplinary team. I mean, the anesthesia team involved early, the ID team involved early also. Early prediction of possibility of airway management and avoidance of that by other methods. I mean, we did epidural in advance to avoid airway manipulation, and that's what happened. Having a list of recommendations written by experts of the field was helping me to decide that time to go for epidural rather than not exposing myself doing epidural. Having a designated OR for COVID patients also helped us to decrease transmission to healthcare workers. Availability and in advance training for using full PPE was helping us a lot to do it more faster. Availability of video calls to meet the patients next day, and the follow-up with the infection control team and home isolation of involved anesthesia team till advised by infection control team to stop that. By this, I concluded my case presentation and happy to answer any questions. Thank you.
Thank you very much, Dr. Muhammad. And the next case will be presented by Dr. Atimad Bantan. She is an anesthesia and pain management consultant. Dr. Atimad, the share screen button and the mic are yours.
Assalamu alaikum wa rahmatullah. Is my voice clear?
Yes, it is. If you have something to do to make it clearer, that would be better. Otherwise, we can hear you.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Omar, for the introduction. And I would like to thank the Saudi Anesthesia Society for inviting me in this webinar to share our experience in maternity hospital during the COVID-19 pandemic. Before I start, I would like to just give you a brief, an idea about my hospital, as I'm working in this hospital more than 10 years. This hospital is one of the Ministry of Health hospital, and it is the only maternity hospital covering Makkah country, city, as no other sector helping us or sharing us in this duty. So you can imagine what kind of difficult and high-risk patients we are receiving. From the beginning of this pandemic, we are following the recommendations and regulations coming from the Ministry of Health and from the Command and Control of Maternal Health and from the Saudi CDC. So from the beginning, we identify operating room. We identified an operating room and we managed to convert it to convert the pressure from positive to negative. And we also implement the signs and the pathway, special pathway for the COVID patients. And we are not testing all our patients coming whether for elective or emergency cases. We are applying this visual triage checklist that's coming from the WIQAYA, the checklist being implemented by the Saudi CDC. And this is the latest one that just if the patient had a history of fever, we can consider that suspected. So we are just, if every patient that score 4 or more than 4, we are handling this patient as suspected till the result of test come out. During this period, we have around 31 pregnant patients, and we deal with them as suspected according to the visual triage checklist. And only 7 out of these 31 became positive. Also, we are applying the Saudi Anesthesia Society airway management for the patient who require general anesthesia. And we are using the portable HEPA filter that's available for such patients. And we tried to create this aerosol box during the period of lockdown, and we couldn't manage to get the real one. My case that I would like to share it with you is a patient that presented as a case of obstructed labor. She was a 20-year-old lady, unbooked, shifted from emergency department with a history of obstructed labor and fetal compromise. She was vitally stable apart from the tachycardia because of the fever, and her investigation were initially within normal. Usually in such cases, when we receive the call for an emergency cesarean that the patient can't wait, we are just asking a few questions as a pre-assessment in history of medical illnesses, fasting hours, initial investigation, and we are concentrating on the visual triage score, whether the signs, the symptoms is only by fever or the patient had other respiratory symptoms or other symptoms in the visual triage score. So once we receive the call, there is a designated team that will be directed to the room that's assigned for the COVID patient, and donning, full donning with full PPE for the whole team. And we are applying also the recommendation that the patient has to wear the surgical mask all the time as possible. This is the PPE that been implemented by our infection control department. As mentioned by our colleague, that we're either the PAPR who have a bear or the N95 with a face shield. And this is being in the simulation in the beginning of the pandemic. For such patient, for this patient, we offer her a spinal anesthesia, and she agreed for that. So spinal anesthesia was given with a 25 gauge needle, and bupivacaine 10 milligram with the fentanyl 20 microns was given to the patient. After checking the level and acceptable level of blood, the procedure, the cesarean was started. Her intraoperative vital signs was stable. She did not require any medication of phenylephrine to support her blood pressure. Baby was delivered with a good upper score. And here, I want to mention, because we don't have an electronic system, we are not writing the anesthesia chart inside the room. We are waiting till they finish the procedure and charting the form outside. At the end, when for recovery of the patient, we are in our policy, we are recovering the patient inside the room or our room. And once the patient is stable, such in spinal anesthesia, we are shifting the patient once we are seeing the signs of resolving of spinal block. And we are discharging the patient to the COVID ward. At the end, of course, the important final step is the duffing for the whole staff, and cleaning and the cleaning the operating room for the next patient is there. I would like to conclude and thank you for this presentation.
Thank you very much, Dr. Atimad. And at this moment, we would like to proceed with the questions and answers. And I have a bunch of questions here that I will, some of them are actually directed to certain presenters and some of them are just posted here. So I'm going to start reading the questions and assigning them. So Razan is asking, what is the percentage of transmission of COVID-19 to anesthesiologists during general anesthesia and regional anesthesia? Meaning, I think that question is to Dr. Kodali, has this been studied of how many people or what is the percentage of this transmission that could happen to anesthesia?
Yeah, no, I don't think the studies have been done, because first of all, it is probably the incidence is very low. But in an institution, if you are going to test all the staff, roughly it is going to be about 0.1%. 0.08 to 0.1% can be COVID positive. But having said that, you know from the news that many healthcare providers have succumbed to this COVID-19. But you know, that is mostly in, I think it is in the ICU settings and taking care in the ICU settings. But I have no idea about how many anesthesiologists, what is the transmission rate to the anesthesiologists while taking care of the COVID-19 in the operating room. And my thinking on that, it should be very low, because we are so good in our protective wear that I think it's going to be very low, but I'm not sure. Maybe some studies will come up in the future.
Okay, thank you very much. Dr. Yaser, a question for you. They say the newborn should be separated from the mother, and they're asking for how long do you think that should be done?
So with regards to newborns of patients who are confirmed COVID-19, again, there's a debate here, but it depends on the center. I think, but we can say here in Saudi Arabia, yes, it is recommended to isolate the baby from the newborn from the mother until she has recovered. But the baby can be discharged, to a caregiver, whether that's the father or a relative who was negative with regards to COVID-19. Others, other societies, like for example, Royal College of Obstetrics and Gynecology, they actually say that newborns can be kept with the mother, but the mother has to take all the necessary precautions when she's going to be breastfeeding her child. But here in Saudi Arabia, according to the MOH guidelines and according to the Saudi Society of Maternal-Fetal Medicine, we actually recommend isolating them.
Yeah, that is true. Actually, at the University of Maryland Medical Center, we are, they are following the Royal College guidelines, which is actually leaving the baby in the same room, but at a distance, and also even breastfeeding them too, with all the precautions as you mentioned.
Perfect. Thank you very much, doctors. And the next question is to Professor Kodali. Do you think that using Duramorph in neuraxial would be somewhat contraindicated in COVID-19 positive patients?
Not to my knowledge. We have used Duramorph in all patients for COVID-19, and there seems to be okay. And even my colleagues, as I understand, use Duramorph, and they didn't report any problems. And my guess is, what is it they are worried for? Is it because of the depression of the respiration, or is it they are worried that simplex virus, they may get a rash? But either way, there is no contraindication as I understand so far.
Okay, the next question is about what you think of anticoagulation use during the care of a confirmed positive COVID-19 pregnant patient, if like the D-dimer is high.
Yeah, so they are all following the anticoagulation prophylaxis for these patients. That is extremely important, because as I already showed you that their platelets are high, their D-dimers are high, and this is actually some of the data which I showed you is actually in those patients who are also anticoagulated too, anticoagulated in the sense, with heparin. So yes, you are absolutely right. They need to take special precautions to prevent thrombosis and pulmonary embolism in these patients.
That was a question by my other teacher, Prof. Abdulaziz Bokar. So always questions straight to the point. The next would be is the HEPA filter, do you think the HEPA filter is as effective as negative pressure room? I don't think so, but Dr. Kodali?
Well, so we had a lot of discussion in this, and currently the infectious, the ID department and the engineering department, they say that it is fairly effective because the operating room is at 32 times per hour, and that has a HEPA filter, and you keep another HEPA filter very close to the head of the patient. Now, there is no data on this to show how much of virus is really grasped by this, but it seems to be a logical approach. And we have started that. And if things go in the wrong direction, certainly we will report it maybe in the next meeting. But that is what it is going, because as I said, it is impractical to follow negative pressure rooms. As our obstetric colleague has said, there are so many numbers, it is impractical to do everything. So we have to come up with a logical thing. So that is why we have two HEPA filters, one next to the patient and one in the OR. And plus we are also covering ourselves very well, right? We are using N95 mask and we are taking all precautions. And so I think with all this, it should be okay. But if we find something different and if I hear something different, certainly I'll report to you.
The next question is a question I also had in mind a while ago when the pandemic first started. And that question is there evidence that CSF contains the coronavirus?
So, so that is a little bit of a controversial issue. And in fact, there is only one case which, on the web, where the patient presented with encephalitis, and the story there was that the patient had some neurological symptoms, and they found that it was positive for coronavirus. So that is why when I was saying that regional is the way to go, it is only on a strict neurological examination. And if the neurological examination is normal, probably regional is fine. That is number one. Number two, we know that certain other viruses, the neurological system has got already. There is nothing new that we are going to do. So therefore it should be okay, but it is it is too early, unless I think, maybe you have to wait for your study where you are doing the CSF analysis in these patients and figure out what is happening. But I don't think there is any data yet on that. But as far as there's no neurological symptoms, and I think we can go ahead with the regional.
Yeah, it is in fact being, I think I saw that it was being studied, whether it is present in CSF or not. I remember something from SARS and MERS, that they actually found them in the brainstem, found the virus in the brainstem of mice. And so hypothesizing that this is the same family of virus, that they could also be present in CSF, but it hasn't, I haven't found any evidence of that.
Yes, exactly. So that is the reason I document in the patient's chart that the neurological examination is fully intact, and hence we are going for regional and then follow up. So far things have been okay, and no one has told me, at least from my colleagues, that they had a problem following the regional anesthesia in a COVID, in a COVID patient.
Do you think that cesarean section would possibly improve the respiratory function of a pregnant patient with COVID-19?
So this is again a controversial issue. As you know, there's some of the data in the past. There was a paper that did some retrospective analysis and said that the indication of cesarean section is an obstetric indication and not to improve the respiratory function. But that is according to that paper. But certainly in our practice, what we have seen, and also elsewhere when I was at Brigham, when we were doing the respiratory compromised patients, delivering the baby does improve the I think the ventilation parameters. But again, we have to wait and see. Our patients, only 3 had cesarean sections, and all of them did well, and some continued pregnancy, and they all did well with the prone positioning too. So that is a controversial thing based on one study. But logically, it makes a difference, because once you remove the baby, the compliance generally improves.
Yeah, I agree with Professor Kodali. I mean, there isn't any strong evidence that terminating the pregnancy or earlier delivery is going to improve the overall maternal outcome or decrease, the rate of mortality. However, previous experience with H1N1 and SARS-CoV showed some improvement on ventilation, oxygenation for those who have severe respiratory failure on mechanical ventilation. So, whatever we're going to decide, a multidisciplinary team review with the family should ideally be conducted to make the decision, considering risks of prematurity, perinatal morbidity, mortality, and possibly maternal morbidity when the patient is less than 37 weeks pregnant.
I think you're absolutely right. You have summarized it very well, actually.
Perfect. And the next question also is for you, Dr. Kodali. I'm sorry, the questions are shuffling up. People are thinking about a lot of things now and asking lots of questions. So that I put my eyes on one question and it shuffles up right away. What would you do in a partial subarachnoid block in a COVID-19 patient?
So suppose you give a partial subarachnoid block and the cesarean section is not urgent. Suppose if the cesarean section is very urgent, then you have to probably go for a GA. Otherwise, if the time permits, we just do what we do normally in a patient where there is a subarachnoid block, is actually do a second, the second epidural or a second spinal with a lower dose. So I don't think there is any change in what you normally do, whether COVID or non-COVID. No, you go with the general terms, and it depends upon your comfort and your comfort level of management, how you normally has been doing in those patients.
Okay, and a question for Dr. Adil. As you said, patient was shifted to isolation recovery room. Why didn't you consider recovery in the same operating room?
Why we should occupy our negative pressure room while we have isolated recovery room? So in our labor suite, we have two ORs. One of them converted to a negative pressure room, and the other one we couldn't. So we use it mainly for emergency CS for COVID-19 patients.
So you probably wanted to free the operating room instead of just making it occupied by that patient?
Yes.
Okay. I think we have covered most of the questions that we have. Thank you everyone for this great webinar. Thank you for attending, and I would like to thank all the expert panelists, Dr. Kodali, Dr. Yaser, Dr. Adil, Dr. Atimad, and Dr. Muhammad. Thank you very much for the great presentations. This is the end of our webinar, and the Saudi Anesthesia Society thanks all the speakers and attendees for their valuable time. We hope that we see all of you in coming activities. The webinar was recorded, and a link to that recording will be sent to you by email. Your CME hours will be counted automatically through the Saudi Commission for Health Specialties if you entered that number when you registered first for this. Thank you very much again. This concludes our webinar, and thank you again.
Thank you.
Thank you very much.
Thank you very much.